Good afternoon, everyone. My name is Rich Garrity. We're here to continue on with our discussions about cross-sector collaboration, but we're going to shift geographies, if we may, into smaller urban areas, not the Atlantas and larger metropolitan areas of the United States, but to the small urban and rural areas. By way of introduction, I started my career 38 years ago, tasked with the creation of a coordination plan to better utilize existing public and human service agency transportation resources in North Carolina. That study, which was initiated by the governor back in 1977, ultimately resulted in a gubernatorial executive order on coordination and began a literally 30 years long process of trying to develop rural transit infrastructure in the state of North Carolina, which at the time was one of the top 10 rural states in terms of population in the United States. And ultimately, we often referred to ourselves as the blind leading the blind. We typically ignored regulations at will, adopted a strategy of common sense and tried to convince the regulators that we were right. And ultimately, the state was recognized for having a model plan for coordination. And to this day, I'm proud to say that we have coordination infrastructure in all 100 counties of the state, something not a lot of other people have been able to achieve. I think at least a half a dozen times this morning, people have referred to first mile, last mile issues. Well, the issues that we address, and this panel probably addresses, are the first 50, last 50 mile issues. And we have a distinguished panel here for you this morning. And without further ado, I'm going to go ahead and ask Judy Kell, who is the hub manager for Pathways to Better Health of Lakeshore up in Wisconsin. She works as Michigan. She works as part of the Muskegon Community Health Project, and she's been in that position since 2012. Without further ado, I'd like to turn it over to Judy.
Thank you very much. Can you hear me all right, or am I reverberating at all? All right, how's that? Is that a bit better? Well, since our esteemed Mr. Garrity talked about me being from Wisconsin, I had loath to have to show you my hand like most people do for Michigan when they make a presentation and they say, exactly where are you from in Michigan? So you have a map. But basically we're across the Lake Michigan from Milwaukee. And the reason I'm putting these little statistics up is because although we're a small county of 172,000 population, we really are a microcosm of the United States in the sense that we have three very urban areas that are entitlement communities. We have rural areas that are large farming areas served by the USDA. We have suburban areas. We have 28 governmental units, if you can imagine, in a community that size, which in and of itself poses a challenge that we'll talk about in a bit. 20% of our children live in poverty. According to the University of Wisconsin, our health status is we are the 81st of 83 counties of healthy at-risk behaviors. So in short, we're overweight, we have a lot of chronic disease, we have hypertension, we have diabetes, we have all kinds of health problems. We have a small part of our population that have some college. For those of you who are familiar with the Trade Adjustment Act, and that is for those individuals, companies that have been displaced because the companies have moved overseas, 22% of our population are trade adjusted. So that kind of gives you an idea of some of the challenges that we face in our community. And one of the reasons that we've been successful with some of the things that we're bringing forward is because of these limitations and the kinds of things that we've had to do. And not last but least, we have a very high number of low birth weight babies, and that will play into transportation shortly. So obviously, healthcare has changed. We need to start thinking out of the box. I hate using that term, but people live in environments that don't support them. My project links people to the social determinants of care: housing, transportation, food, utility assistance, anything that can improve their health status. Because one of the things that we discovered through our community health needs assessment, and how many of you are familiar with community health needs assessments and the requirements? Well, if you'll give me a minute, each nonprofit hospital has to do a community needs assessment as part of their filings with the IRS to maintain their nonprofit tax status. And that community needs assessment really looks at what people in the community say has to happen to improve their health status. The hospitals then are required in their implementation strategy to develop goals and objectives with measurable outcomes. And the reason that this is very important is when we talk a little bit further on about our outcomes, that measurable outcomes of the things that they have done to improve health status in the communities. So for example, in our community, one of the biggest things that we saw was that care coordination was desperately needed, and not just between doctors and nurses and specialty clinics. When we talked about care coordination, we talked about everything, especially as it related to transportation, housing, food, and utility assistance, with transportation being our number one barrier for our population. So we have had at the Health Project, which is the community benefit ministry of the Mercy Health System, community health workers, and our esteemed speaker earlier talked about his community health associates this morning. We call them community health workers, and they are indigenous to their community. They are the trusted members of people in the community that can link people to resources. And they do many things in our community, one of which is our transit system has trained our community health workers to be able to teach people how to use the bus system, how to call, how to get on routes. They'll travel on the routes with them so that people can get to and from their appointments as part of their healthcare system. So these are just a picture of a few of my 30 health workers, with 5 more coming on board next week. What do? Well, I am the hub manager, and the hub manager coordinates all of the health care and social determinants of care for people in our program. And we provide clinical oversight as well to those community health workers who are deployed to access those services. And I also have in my budget a transportation line, because it became very clear to us when we first got our initial grant from the Centers for Medicare and Medicaid that I could either ask for and receive administrative money, additional administrative money, or I could put that same dollar amount into transportation. It was the feeling of our group as we were putting this project forward that it would be great to have another administrator, but it would be more important that we actually got people to their doctor's appointments, to their pharmacy appointments. And as the grant ended and we talk about our data, you'll see that the community benefit dollars from our health system are now paying for this project along with the transportation dollars. The process, anybody can refer into the hub. I refer out to our partners in the community, and they deploy the community health workers. These are our tools. I'm going to go through them very quickly. It's an electronic health record. We use an evidence-based system so that services are ended until nobody is terminated from the program until they get their services. Not that they're linked to their services, but that they actually receive them. And as you can see, these are our sample pathways, with transportation being the #1 barrier in our community. Who are our community partners? Well, when we started this project and had this great idea about adding transportation to community health workers, I would like to say that our local government and our local transit agency were really on board with this. But it was something new and different. But we were very fortunate because we were designated by the EPA as a sustainable community. And as a result of doing that, they provided us with a transportation consultant who came in and engaged all 28 governmental units, everyone else in the community. And as a result of that, a transportation plan was developed that included mobility coordinators, cross-sector collaboration, a willingness to really work among us as a partnership. And on top of that, we were also able to get 3 buses funded by DOT, so thank you, to extend our routes out to 3 rural areas where we had a lot of patients but no access other than dial-a-ride. And so we were very careful with this transportation study so that we could really take a look at where a lot of our patients were going and to really try and connect the new clinics that were being built out in the more rural areas so that they would be on the new transit routes. That also very selfishly on my part saved me some money out of my transportation budget because it was cheaper for me to buy a bus pass for the patients rather than to have to pay for the dial-a-ride costs or the cab fares. So we're very pleased with our contract that we have with the Muskegon County MAT system now. We obviously have private cabs. We have 10 care coordinating agencies that deploy the health workers. That includes our federally qualified health centers, our area agency on aging, our health departments, and a variety of other social service agencies. Our churches, our libraries, and our public housing, what do? They provide us space because one of the things our community health workers do is they do a 6-week course on chronic disease management. Now you're probably saying to yourself, what does that have to do with transportation? Well, we provide transportation to that, and I'm told I have 2 minutes. And part of the reason that we do that is because it helps end the isolation that the people have. They've formed relationships. CMS gave us initial guidance this week, actually last week when we got it, that showed that our spending was lower than the comparison group prior to and after our program. That our health care, the data suggested that our health care was better. And here's our impact. Patients in our healthy pregnancy program, for some reason, they like to take the ambulance to the emergency department. We now have them taking cabs or the bus. We've reduced the cost. Their health care has remained the same. And quite frankly, with the intervention, the cost per case is about $2,800 less per person, in addition to the fact that their outcomes are equivalent to those on commercial insurance. Patients in all our programs are provided transportation to their AA and NA meetings along with treatment. We had 98 patients that cost our hospital system $9 million. Of that 98 patients, 96 did not have transportation. pre and post intervention, we were able to show the hospital system a reduction of $2.4 million worth of costs in emergency department use, and the increase in primary care visits was 1,500 to 6,500 for that 98 patients. And obviously, we've decreased social isolation. What are our barriers? We've talked about them all today. Crossing county lines, definition of disability is confusing to some of our partners. We have a lack of data, although I keep spreadsheets on everything, and now with our mobile system, we're able to keep track of data to show our return on investment. What are our opportunities? Obviously, we found a champion in our community to do this kind of work. We've institutionalized the work through the use of community benefit dollars through the health system. We encourage people to participate in their local community needs assessments and access those dollars as we go forward. And finally, we have now also been designated through the state of Michigan as a state innovation model site for an accountable care organization using the value-based model that we were talking about earlier this morning. And we are also now a community health innovation region for the next 3 years. So our community was small, we were poor, we had a lot of problems, and the only thing that we could do was talk to each other, and talk to each other, and try and make things work in the best way we can. Thank you.